Dr. Ruth, and I'm a faculty member at Our Lady of the Lake University at the Wharton School of Social Service. I have for many years been interested both in the subject of ethics and the subject of aging. And I have the opportunity to bring those two subjects together today to talk with you about some of the ethical issues facing the family and the dying patient. I'm also going to suggest, because we have a small audience here in the studio, that if you have a question while I'm talking and prefer to wait until the end, fine. But if not, just put your hand up so that I know, and I'll stop and we can talk, and then I'll go on. You also all should have some handouts, and I'll indicate when referring to those might be helpful for you. As I think we're all aware, there are increasing numbers of older adults in the United States. Actually, globally, there is an aging of the population. In the United States, what that means is social workers, such as myself and other healthcare professionals, are facing a number of problematic situations and dilemmas, some of them ethical dilemmas. By the end of the last century, 4.3 million persons were over the age of 85, 70,000 of whom were over 100 years old. The number of 100-year-old people is expected to double with each decade. And as you know, this is due to better nutrition, better health care, but it does present, again, the issue of how do you care for and help make responsible decisions for the person who is coming to the end of that long life period. 85% of Americans die in some kind of health care facility. Of this group, 70% choose to withhold life-sustaining treatment. When a person is dying, for the healthcare professional, the person and the family, ethical dilemmas may arise out of conflict between two principles. And if you will refer there to both the overhead and to your handout, the first principle is that of self-determination, or the principle of autonomy. That principle states that a person most affected by a decision should and has the right to make that decision about themselves. Now, self-determination is a first-order principle in American society. That's not true in every society, some societies that are more group-oriented, but we are very individualistic in this society. And so a person's right and freedom to make their own choices is critical. There may be a conflict between self-determination and the benefit principle, which says that the medical profession has the knowledge and skills necessary to best assure a positive outcome and is therefore responsible for making the decision that will secure the best benefit for the patient. This takes on special significance when a patient makes a decision that the healthcare professional thinks will result in harm to him or herself. If we are not careful, this benefit principle can become paternalism, which overrides the client's self-determination. One way in which this can happen, there are three different ways this can happen. One way in which this can happen is by withholding information from a client or patient about his or her condition. And I will give you an example. All of these examples are from practice, some of them from my students and some from other practitioners. Marcia was a social worker in a general hospital assigned primarily to the medical surgery unit, and that works with cancer patients. One patient, who we'll call Michael, was 68 years old. He was admitted for exploratory surgery on his abdomen. He was described as frail and by the attending physician as emotionally labile, or also fragile emotionally. One afternoon, Marcia was approached by Michael's daughter, Ellen, who told Marcia that her father's physician had just informed her that the lab report from the exploratory surgery shows that her father had terminal cancer. Ellen said she and the family were in shock. They never imagined, she said, that he was this sick. And we just cannot tell him that his life is over, because he will not be able to handle it. Ellen told Marcia that she and the rest of the family have decided that they do not want the hospital staff to tell her father that he's terminally ill, because they think he will then fall apart. So Ellen asks the social worker to explain this to the attending physician, and to ask the attending physician to cooperate with the family. So the question is, what are the issues in this situation? On one hand, what we have are reports from the attending physician that this man is very emotionally fragile. And we also have reports from the family that this is not something he could handle without falling apart. On the other hand, Michael is not senile and does not have Alzheimer's, and is able to think coherently. And on the basis of self-determination, Michael has the right to make his own decision about what he does next. But if he is not provided with the information, then he cannot exercise his self-determination. So if we decide to withhold information on behalf of the family, or because we judge that the patient can't handle it, then we are robbing the patient of their right to make decisions. What is, and the question is, in these kinds of situations, what is the best and correct ethical response? Now, every profession has a different way of determining that. But most professions have a code of ethics. And if the code of ethics contains the answer in terms of guidelines of what to do, then the professional, whether it be a physician or a nurse or a social worker, are to follow it. But in some cases, the code of ethics is not, in most cases, the code of ethics is not internally consistent. And so you may have two things that the code of ethics tells you to do, and you can't do both. For example, in this situation, it brings us back to social workers are required to ensure the client's right to self-determination. So on that basis, I would say, no, I cannot help you because your father has the right to know. At the same time, as a social worker, we are committed to doing everything we can to ensure the well-being of the client. So if I insist on the self-determination and the man finds out and then falls into severe depression, what have I done to the quality and possibly the length of his life? What most professions then do is, either in a hospital you have an ethics committee that you can go to that discusses the issue. You can also, most professions prioritize. They say, given all of the things that we want to follow ethically, what has priority? What is most important? Now, most professions prioritize the preservation of life over any other value, even confidentiality, truthfulness, self-determination. And if one followed that kind of prioritizing, that preservation of life, and one decided that Michael, it might actually shorten his life to know of his cancer, then one might decide to not tell him. So again, it's not that there's a right and a wrong answer. What it allows me always to appreciate is the complexity of these kinds of decisions. The second form of paternalism involves actually lying to clients for their own good, in contrast to merely withholding information. And this occurs if we deliberately give clients false information about some aspect of their lives, perhaps in response to their questions. This is particularly tempting when you're dealing with a child who may say, who is diagnosed with an untreatable brain tumor and says, "Am I going to be all right?" The tendency is to say yes, and maybe to avoid it by saying everything's going to be all right. But really everything is not going to be all right. I was watching, I'm forgetting now what the television show was, but the question was, would you tell a woman when she's just been diagnosed with breast cancer? And she says, "This is terrible, is everything going to work out?" And in the scenario, which I think was public television again, the physician said, "Everything will be all right." But really, the physician can't know that. So what I think operates there, having been in that position myself as a social worker, is that sometimes we ourselves cannot bear the idea that the patient or client has the condition that they have. We ourselves have not yet accepted it. And so we cannot face communicating it to them because we can't handle their realization when we haven't found our own realization. The third form of paternalism involves physical interference with clients against their wishes for their own good. For example, forcing individuals to receive medical treatment, which has been has gone to the Supreme Court several times, or forcing individuals to reside in a nursing home against their wishes, are common forms of paternalism. Here again, this is a very complex situation. If a person says, "I want to stay in my own home," but you think that if they stay in their own home, they will fall, or the chances are high that they will die, and you decide, as if you're their child, to have them declared incompetent so that you can put them, have the decision to put them in a nursing home. You may be protecting their life, but you have taken away something very critical to their life, which is their right to choose. So these are all ways in which looking after our patients and clients can go that next step. And again, it's by withholding information, by lying, or by physically interfering with the client's self-determination. To protect self-determination, in this country, clients and patients must consent to treatment procedures. So we have the concept of informed consent. Informed consent is an ethical issue when working with people of all ages. It is critical when working with people who are elderly. Informed consent implies a rational process. The person has the right to understand the situation, the choices, and the projected results of the decision. In the case of aging persons who are clearly incompetent, The courts may appoint a guardian. But there are many older people who have a limited capacity for understanding and decision making, but who are still legally competent. And they have good and bad days. And one day they're more in touch and able to think clearly, and another day they're more confused. Should the social worker or physician do what they think is right for that client or patient? I think there is a tendency, because of ageism, to discount the capacities of older people, especially when they are physically very frail. We tend to think they are also then mentally very frail. And there is also a tendency to not go the mile for the older client. And that means it may take longer for a person to understand the situation if they are sometimes confused than it would for a person who is not confused. But will you or I, as a healthcare professional, take the time to go over and over the decisions to be made until the person understands? Will we, if someone's main language is Spanish but they have some English, keep trying to explain it in English rather than getting an interpreter? How will we communicate with the person who is hard of hearing so that they hear everything that they need to hear from us? What do we do when people are not literate? What kind of consent is acceptable? Is verbal consent acceptable, or is it only written consent? What does it mean when you say, Mrs. H, you can no longer live at home and need to go into a nursing home, and the client says nothing? Do you take that as consent? What about, as we all know, we change our minds fairly regularly. I change my mind. What happens when someone in the past has said, if I ever get so bad that I can't think straight all the time, just put me in a nursing home? But then the time comes when they are confused and they say, I do not want to go into a nursing home. What do you do with that situation? Once again, I think what's important is that it's not that there are answers, because there are answers, but it's to each individual situation. It is to appreciate the complexity. Now, in an effort to reduce the possibility of ethical conflicts for the health providers and the families, a variety of advanced directives have been developed and have become law. Advanced directives are legal documents that allow patients to plan for medical treatment decisions while they're of sound mind. Advanced directives were promoted in the early 1990s after the Federal Patient Self-Determination Act of 1991. And I'm going to put on the screen and then move down, if you can see the timeline. It isn't just the Self-Determination Act. We will see the steps in terms of ensuring that and bringing clarity to end-of-life decisions in this country. You will see that in 1967, that was when the members of the Euthanasia Society of America devised the first living will. So it's been with us, the living will concept, for a long time. In 1973, the American Hospital Association created the Patient's Bill of Rights, including the right of informed consent, which I was just discussing, and the right to refuse treatment. In 1976, the California Natural Death Act was the nation's first right to die statute. in 1976. Also, New Jersey Supreme Court in the Quinlan decision established the right of the patient's wishes over the state's duty to preserve life. That was Catherine Ann Quinlan. In 1997, the right to refuse treatment or treatment refusal laws were passed in a number of states, and you'll see that Texas was one of those states. By 1984, 22 states and the District of Columbia had statutes that recognized advance directives. In 1990, the U.S. Supreme Court's Cruzan decision recognized the right to refuse medical treatment, and that it is guaranteed by the Constitution. Also in 1990, what I just referred to, the U.S. Congress passed the Patient Self-Determination Act, the first federal act dealing with advance directives. In 1991, Pennsylvania became the 50th state to enact advance directive legislation, so that now all states have such legislation. In 1997, there was an attempt to redo the 1976, I believe it was 76, yes, the 76 Act in Texas, the advance directives, because there were a lot of inconsistencies and holes in it. But the Texas governor at that time vetoed legislation attempting to reconcile the inconsistencies. However, in 1999, Senate Bill 1260 was approved and signed into law in Texas. The law eliminated inconsistencies, enhanced patient autonomy, and gave physicians a more useful set of documents to guide end-of-life decision-making. So presently, we are operating under 1999 legislation in Texas. Now, what that legislation does and the features of it I want to talk with you about. The directives, the 1977 it was, not 76, the directives to physician or living will became in 1999 the directive to physicians and family or surrogate. This was done to demonstrate that it was not only a directive to physicians, but that families also needed to respect the person's advance directives. The new law includes a process for dealing with disagreements between the physician and a patient's family or surrogate, with or without a directive to physician. This was very critical because there were many times, as you could see implicitly in the case example I gave earlier, going to be conflict between perhaps the patient, but conflict then between the family and the medical person. The new law requires a mandatory ethics consultation. And this means, in this case, if the patient's family wants the person kept on life support or given extreme measures of support, and the physician thinks it is a case of futility, then the physician is required to do an ethics consultation to make a reasonable attempt to transfer the patient to another physician or institution willing to honor the directive or what the family wants. And in the case of medical futility disputes, to continue life-sustaining procedures for at least 10 days after the ethics committee, even if they've decided not to maintain life support, to maintain it for 10 days afterwards, to allow the family to take action. Another piece, I wanted to give you a case study in here so that we don't get, this can sound very abstract, but in fact, of course, it affects people very close to us. A man came in with severe Alzheimer's in his 80s with heart failure, and he also was aspirating liquids and solids. A PEG tube, feeding tube was considered, and the gastroenterology service was brought in. The gastroenterologist felt a PEG tube was not indicated because the patient's severely impaired mental state, poor prognosis, and inadequate data showing that a PEG tube decreases aspiration. The patient was disoriented to person, place, and time and did not recognize his family. The patient was a widower living with his son and daughter-in-law. Now the son requested that everything be done, including placement of a PEG tube. The son also explicitly requested that the patient be resuscitated in the event of cardiopulmonary arrest. The family actually wanted to take the patient home and care for him until he dies. The internal medicine resident, who had cared for this patient in the past, does not agree with the request and tells the family this is a case of medical futility. And the negotiation seems to have reached an impasse. So what are the correct steps to take? Well, first you would ascertain if there has been an advance directive. If there is, you follow it. However, if there is no advance directive, then the family has the right to make the decision that the patient, if competent, would have made for himself. This has been the case in dealing with end-of-life ethical conflicts until a California ruling in a case called Wetland, Mr. Wetland, in August 14th of this past year. The California Supreme Court found that verbally expressed wishes about end of life did not constitute clear and convincing evidence of a patient's wishes. And they concluded that family members could not remove the feeding tube from a conscious but severely damaged loved one unless they could clearly show that the patient would have wanted to die. Now, his wife and other family members said that the patient had told them earlier he did not wish to be given extraordinary life-sustaining treatment if he became unable to express his own wishes. But he did not leave an advance directive. And the court's opinion was that the family saying that that their loved one had told them was not sufficient. Well, what that really means is we have got to do better at getting advance directives, because we now have a precedent for not accepting verbal. The new law requires two physicians in order to stop supportive means for a patient. If there are no available relatives, there's no advance directives. Two physicians need to agree to make that decision. In the new law, the patient can request or refuse ongoing aggressive treatment even when he or she has not executed an advance directive. Okay? So again, it's too bad these things have to be done legally, but legally what they're saying is you can change your mind even if you put it in writing. What we know is that this law in Texas does a little better job of reducing the dilemmas for the healthcare professional and of supporting the self-determination of the client by increasing the clarity of advance directives. But when advance directives were developed, it was thought that it would diminish the need for physicians and social workers and nurses to discuss end-of-life issues, because people would have clear what they wanted to have done. However, there have been numerous studies, and what is suggested is that advance directives do not significantly affect the aggressiveness of costs of subsequent care and do not change end-of-life decision-making in the ICU or hospital settings. So they have not done what people had hoped they would do. Furthermore, only a small percentage of elderly adults prepare advance directives before a health crisis occurs. And the campaign to get people to sign advance directives has not been very successful. One reason for the minimal acceptance of advance directives is that patients generally are given information about their rights when they enter hospitals and nursing homes because of illness or cognitive impairment, and they and their families are overwhelmed. This is a poor time to consider end-of-life decisions or to choose health care arrangements. Those decisions require reflection and conversations, and they need to be completed long before a person is near death or medically compromised or unable to make a choice. But studies show that frequently and for a number of reasons, patients wait for their health care providers to bring up the subject, and health care providers wait for the patients to bring up the subject. And it was noted by one research center that was researching the subject, lack of communication between patients and physicians and misunderstandings about the appropriateness and purpose of advance directives may explain why completion rates remain low. When we're talking about the law, we again are saying we're getting as precise with the law and as complete as we can get. What we haven't attended to is the ethical dilemmas that families, individuals, and healthcare professionals face. And because we haven't, and people are not comfortable or sure about what they should do, and I'm meaning by this patients, families, and social workers and nurses and physicians. Let me take it from the health professional, because we are not prepared to deal with the ethical issues involved ourselves and the responsibility. We don't discuss it with patients. And because patients and families aren't prepared, they don't discuss it. And if people are not willing to talk about end-of-life issues until the end of life, then it is very difficult to ensure self-determination. So I would say as a healthcare professional, one of the things that I'm committed to is talking before people are in a life crisis with them, and learning to talk about advance directives in such a way and the decisions that are involved that the client or patient has a chance to make that proactively rather than in a crisis situation. Questions, comments?
How do your younger students feel about that particular comment?
Oh, it's when students enter the undergraduate or the graduate program in social work, the younger students are not prepared, as you would expect. They haven't even dealt with in their 20s with their own mortality. Not to mention their parents, their grandparents. And I do find, because we have many what we call mature students, non-traditional students, that students who come to us who have had more life experience have given some thought and are more ready to talk with clients about end of life. But for the young student, it is incredibly difficult. Now, we talk about it, we talk about why it's important and why informed consent is a critical freedom of the client that they're required to ensure. But it's just as in the case that the research has shown, just telling them that they should do it doesn't mean it's going to happen. It requires a lot of training and self-awareness. I'm wondering, because we have two other healthcare professionals in the room, if you have developed a way or an approach or a timing for talking with your patients about end-of-life decisions. How do you approach this? Do either of you, have you had the opportunity to talk with patients? Have you found a way to do that is both humane and caring and yet informative?
I actually have done it in nursing since the latest law was passed in Texas, the 99. But in my family situation, I'm the patriarch.
Uh-huh.
And I have a 52-year-old teenage daughter who comes under that heading. But anyway, in each of our cases, we have already designated. I had to make the one out for my wife. And as late as yesterday, I took it in to the doctor that is associated with us. And he read over each thing that we had, and he said, well, I approve of those. And then he turned coyly and said, as if it made any difference, you know. But
you understand what he meant in terms of this law.
And because what we had in there, in both the case of my daughter, my wife, and me, was that there was to be no CPR or intubation if there was no detectable heartbeat. That rescue breathing could be started if there was a detectable heartbeat. Didn't want one I was choking, you know, and not anything being done, and that peg feeding would not be considered. And so those were
So you as a well, you and your daughter came together, and did you talk about it?
Daughter and I talked about it, and talked about it concerning her, my wife and her mother.
So are these advanced directives for whom?
For my wife, and we also have for my daughter and me.
And so you made a decision that all three of you will have the same advanced directive.
My daughter is an EMT, so she deals with it every day. And I'm not as young as I was 50 years ago. So, but anyway, so that's the way we approached it. And I don't know, when I get back into the nursing field, if I'm allowed that privilege, I'm going to be a lot more aggressive. And I think you said, or maybe I was just reading it in, that admission is not the place for it.
Right.
Neither is the next day when the social worker usually comes by.
Right.
But as we work together with the patient and with the family.
That's right. That there are two things that the point of crisis, when there's admission to a hospital, or as you say, the day after, is not the time when the family's in chaos. Coming to a decision about advanced directives, ideally, is a process. That means it takes place over time through discussions and reflection and consultation with people that you value. And that can't go on at the point of emergency. So if it can be done, the time to do it is when basically you are well, is the time to make the advanced directive, not when you are dying. But what that requires is that we as healthcare professionals be comfortable enough to talk with people, not when they are dying, and not to be thinking that, oh, you're just going to be depressing them, and why talk about such a negative thing, and be able to explain why it is important to talk about early.
You didn't use an illustration on this, but there was a comment concerning if the children, the adult children, decided to put mother in the nursing home, and she decided against it. Now, in that case, if they have seen signs where she would be dangerous to herself, if they didn't take some legal action, would they be liable if she did injure herself if she stayed at home?
I will give you my opinion, but it's not a legal
Oh, it's not
opinion.
legal.
But I think we have a lawyer who will be coming in and can give you a legal opinion. But my understanding is that no, you would not be liable. The children would not be liable. I think the issue is, has she been proven to be unable to make her own decisions, and has someone else assumed guardianship? In that case, there is responsibility. But if they have not, and I think this is where a lot of grown kids find themselves, grown kids, your age, my age, find themselves with their older parents, that they don't have guardianship, but they really don't think the person can manage. But the person has the right to make their decision, and part of what's keeping the 80 or 90-year-old person alive is that right to make decisions. So, so are we going to try to overcome that right? It's a hard one. Well, thank you very much.
Very good.
We don't have any questions.
Well, I think
We
you
have
had
a
one,
lot
and then
of
I
them.
think we had some.
We had a lot of discussion.